Thanks for joining. We'll begin in a moment.
All right, well, welcome everyone. I'm really excited to have you all here. I think this is the third installment of the boot camp. Today, I'm tasked with talking about analgesics and acute pain. My name is Patrick Meyer. I'm one of the regional anesthesiologists at the University of Wisconsin, and I'm one of the associate program directors for the residency. So I'm really excited to have you with us. We have a lot of content to go through. To start, I don't have any disclosures for you today. I was tasked with talking about chapters 9, 18, and 40, which cover opioids, peripheral nerve blocks, and perioperative pain management. So there's a lot of material to get through. My goal with this lecture is absolutely not to provide a comprehensive review. I really am here to try to provide some clinical context to information that you read in these chapters. The reason I'm giving this and not, say, a pharmacist is because not that I'm an expert in, opioid pharmacology, but rather because I have some of the clinical context that makes this information useful to you starting as future anesthesiologists. I do want this to be an interactive as we can. You guys aren't able to talk and join in with me in a discussion. So instead, I'm really going to use the chat function. So I really hope you guys will just take some time to jump in with answers. Nobody's going to judge you if you're wrong. I'm not going to judge you if you're wrong. It's just a way for us to engage as we work through some of this material. So we're going to go through a series of 4 cases to explore these topics and use things that I see in everyday clinical practice to learn these concepts. So first case of the day, you are, let's say, driving in early in the morning to go in and start setting up your case. You get a page on your way in. It says, patient wants to discuss opioid treatment plan. So you're thinking, okay, I haven't gotten a page like that so early in the morning. That's interesting. I'm a little worried what that means. All you remember is you have a 56-year-old woman with end-stage renal disease who's getting sinus surgery. So you get into the hospital, quickly set up some of your stuff in your room, and you go see the patient to try to figure out what's going on. The patient is very pleasant. She states she was given codeine following her surgery when she was in her 20s, and she really got no pain relief from that medication. So she's really concerned about pain after this surgery since it was such a bad experience for her last time, and she wants to be given something, quote, stronger this time. So why don't you guys use your chat here and tell me, like, what's going through your mind here? Is she lying or misremembering? Is she drug seeking? What do you guys think? Awesome. So I see some comments here. Some people lack the ability to process codeine into its active metabolite. Absolutely. So let's look at that. So just codeine, just like most opioids you might remember, are broken down in the liver. And then some of them are excreted unchanged in the kidney. Some of it is broken down into metabolites and then excreted. That's how the majority of opioids work. So really for codeine, the reason that it's interesting is that it gets its analgesic efficacy from one of its metabolites, which is morphine. And that's broken down by the CYP2D6 enzyme. So if you don't have CYP2D6 enzyme, or it's not working properly, you really get no analgesic benefit from the codeine itself. And it happens to be that about 10% of the Caucasian population lack or have a frame shift mutation in this enzyme, and as a result, don't respond to codeine. There's other people that actually have this enzyme that is in overdrive and produces more morphine. So the effects with codeine can be a little bit unpredictable. And it's why it's fallen out of favor a lot in clinical practice. Okay, so we've decided maybe that was her case. So back to our case then. We still are getting sinus surgery today. What do you guys think about morphine then? I mean, we saw that if she doesn't have that enzyme, we could bypass that step and instead just give her morphine in this case. Would be stronger. It should work in her. Type some stuff in the chat. What do you guys think about this for this patient instead? Looks like Chris had said we should probably be careful with morphine and end-stage renal disease previously. So let's jump to that. Why? So again, this is two graphs from our chapter that shows the breakdown of morphine. So as morphine is broken down over time, we see two metabolites that are created. So I'm going to call them M3G and M6G. In normal kidneys, you can see that as morphine is broken down, those are created, but then those taper down over time as well. In the kidney failure patient, you'll see that those accumulate because they're excreted by the kidneys. It turns out that M3G is inactive as an analgesic. So it doesn't really have an effect, but it can cause neurotoxicity. M6G is actually a really potent analgesic. And so in someone with kidney failure, what you really worry about is that metabolite building up and leading to really most severely that respiratory depression that you can see that can put their life at risk. So I think we figured out here, we don't want to use codeine, we don't want to use morphine. So if we go back, what opioids are safe? So Andrew here says we should use a synthetic opioid like fentanyl. I think that's a wonderful idea. So if we look at the structure of different opioids here, morphine and codeine very similar. We saw how they're converted between them. Meperidine is kind of the opioid that a lot of the semi-synthetics are more structurally related to, such as fentanyl, which is shown here. I really don't want you spending much more time than that looking at these structures. You can see in the graph here that fentanyl, alfentanil, those medications are both thought to be safe in renal failure patients. Hydromorphone, someone asked about hydromorphone. It's a little controversial. So people say it's relatively safe, especially at reasonable doses. You may need to reduce dose and you should definitely carefully monitor it. There is a byproduct of hydromorphone that has some neuroexcitatory function, at least in animals, so it could be a potentially dangerous drug in a human too. But most people have been able to give hydromorphone to an end-stage renal disease patient at low doses without problem. Morphine and codeine, we already talked about those and the reasons, so we were going to avoid those. So let's say we decide we're going to use fentanyl in the OR for this sinus surgery. I think that's a very reasonable choice. It's safe in terms of metabolism. So we proceed with the case with a synthetic opioid like fentanyl. Sinus surgery goes uneventful because of all the great work you guys have been putting in. You know all about induction with IV agents. You took great care of her. Everything went so smoothly in the operating room. So you transfer her to the PACU or the post anesthesia care unit and hand off to the nurse there to start setting up for your second case that you have coming when your pager buzzes again. So it says patient is shivering in recovery room. Meperidine question mark. And from reading this chapter, you guys kind of remember meperidine is great for preventing perioperative shivering or treating the perioperative shivering that can happen after anesthesia. So what do you guys think about meperidine in this case? Should we put in an order quick? Pratik says, no, end-stage renal disease. I agree. So meperidine's another one that we have to be careful with, an end-stage renal disease. So it has a metabolite known as normeperidine that can build up. And puts people at risk of seizures. So while a low dose might be acceptable, it's really not a medicine that we want to use a lot in this patient population. All right, I think that patient finally recovers well. So we get to shift our attention a little bit here now to our second case of the day instead. So we have a 60-year-old female now with a past medical history notable for hyperparathyroidism, who presents for an outpatient parathyroidectomy, where they're going to take out the hyperactive gland. I don't know if you guys have seen these cases, but we often use a specialized tube that uses EMG monitoring to detect stimulation of the vocal cords, muscles, and movement of the vocal cords, that then emits a sound that lets the surgeon know that their electrocautery device is getting close or signal or causing the recurrent laryngeal nerve to fire. So one of the risks with this surgery is that the recurrent laryngeal nerve passes right through this area where they're operating, and you can damage that. So we use these special tubes as another marker to help them identify that and alert us if they're getting too close to it. So all that to say is that in order to let those vocal cords move, we can't use long-acting neuromuscular blockade. So in this case, a lot of times people use succinylcholine and have that neuromuscular blockade fade off so that they can monitor safely during the procedure. You've seen a case like this before. You kind of remember that patient was a little bit stimulated in the operating room under anesthesia, but then really didn't have a ton of pain afterwards. I think that's pretty common. So you're trying to design an opioid plan that works in the operating room, but doesn't need to hang around long afterwards. And, we had pretty good success with our last patient using medication like fentanyl. So I think that's a reasonable way to proceed with this case. So let's say we decide we're going to do an induction. We're going to provide a little bit of fentanyl for this patient in the operating room. So you do that, things go well, the tube's in, and they are just about to start, they just start surgical incision, and the patient moves despite being under 1 mac of gas. So you got your angry surgeon here. He'd like to get started on his surgery, and the patient is coughing and moving. You're kind of new to this, and you thought you had a good plan going in, but you start to sweat a little bit because you're not quite sure what to do. But then you remember from your boot camp lectures that opioid medication is synergistic with our volatile anesthetics and can greatly decrease the MAC required for your isoflurane. So in this case, you can see the chart over here on the right. As the plasma concentration of fentanyl increases, the amount of isoflurane required to prevent movement in a patient goes down. And things you'll notice are that even at moderate doses or moderate concentrations of an opioid, the amount of volatile you need substantially is decreased. The other thing I want you to notice is that when you go all the way to the high end of the opioid concentration graph here, the need for isoflurane in this case does not go to 0. So it's not an anesthetic. Opioids are not full anesthetics, but they can substantially decrease the amount of volatile anesthetic you need and would help significantly in this case. So you also remember from your bolus front end kinetics that fentanyl is a great medication because it increases significantly in the first few minutes and then tapers off within pretty significantly over the course of about a half an hour here. So it'd be a great medication for this type of patient that you don't expect to have a lot of pain afterwards. So you give another bolus of fentanyl and you proceed with the case. The patient stops moving, so the surgeon's happy. They proceed with the surgery. But then 30 minutes later, same thing happens again. So this time you think to yourself, I have this fentanyl. It's fast on. It's relatively fast off. It seems to be working how I want it to work. instead of doing this every half an hour or so, why don't I just start a fentanyl infusion so I don't have to keep doing this? The surgeon doesn't have to keep looking at me angry every time this patient coughs. So you do it. You start an infusion. You're feeling pretty proud of yourself. It's July, so as expected, the case goes a lot longer than anticipated. Everyone's learning, including us. But they're just starting closure. So you decide, I'm going to turn off my fentanyl infusion. This is going to take them a half an hour or so, 20 minutes to finish closure. I'll start blowing off my volatile anesthetic. I'm going to impress my attending with some of my quick wake-up skills here. Afterwards, though, the patient is not waking up. So you're thinking to yourself, I used a short-acting opioid like fentanyl. I turned it off a long time ago. So what's going on? What do you guys think? Critique says context-sensitive halftime. Exactly. Let's look at that. So first off, why is this patient not waking up or not breathing? So you might remember this graph in the upper right that opioids act to kind of reset your drive to breathe, both to hypoxia and in response to carbon dioxide. It shifts that curve to the right. So as your PaCO2 increases, normally that causes you to significantly increase your minute ventilation to blow that CO2 back off. With opioids, that graph gets shifted to the right and blunted, so you don't have that response. So in this patient, even though they're not breathing and they don't have volatile anesthetic on anymore, that PaCO2 is not triggering them to breathe like a normal patient because of the amount of opioid we have on board. So what is context-sensitive halftime then? I think this is a really important thing for you guys to realize is that drugs behave differently in a bolus form and in an infusion form. And knowing that and learning these different drugs that you're going to be using a lot is really important. So context-sensitive halftime by definition is the time required to achieve a 50% decrease in concentration after stopping a continuous steady state infusion. So despite fentanyl in bolus form being relatively fast on and relatively fast off, it's actually incredibly slow coming off after a constant concentration steady state infusion is turned off. You can see in the graph on the right here, fentanyl builds up relatively quickly. So within a couple hours here, you can see the time to decrease to 50% also rises to several hours or more in length. So in this case, running a fentanyl infusion for a few hours while they took out this lady's parathyroid glands was not a great choice. So what in fact what medication should we have used instead based on this chart? That might have given us a patient that is motionless without neuromuscular blockade, but goes away quickly despite having an infusion running. So someone says alfentanil, dexmedetomidine. I think those are reasonable options. So if you look at the chart here, alfentanil is a good choice. It does not build up. It comes off quickly. Remifentanil, I think, is even a better choice. So they're both fast on. Remifentanil works really quickly. Someone type in the chat, how does remifentanil metabolized? So this is another exception to the liver and kidney metabolism. It's a unique one. Anybody know? How is it metabolized? Yeah, someone said RBCs. So yeah, it's actually broken down by esterases, predominantly located in red blood cells. So perfect, great. So even after a steady state infusion, within just a few minutes, remifentanil is gone. So you can run that for a case for 8 hours and turn that infusion off, and really consistently within that amount of time, those esterases break down that medication and the opioid effect goes away quickly. So in this case, would be well set up to add some remifentanil, and actually commonly we do that for these types of procedures if someone's coughing or we can't get them to remain motionless because the area where they're working on the trachea is very stimulating. The thing to know about remifentanil is that sometimes it's been associated with potentially hyperalgesia post-op or acute opioid tolerance just from that period that it was working. But if the case is thought to be pretty pain-free post-operatively or minimal pain afterwards, that is a good case to use it for because you won't run into as many issues related to those known side effects. All right, so we're still in the operating room though. We've realized our error, but we would like to still wake this patient up successfully. So what should we give this patient in this case? We think that they have too much opioid on board and they're not waking up. What can we give them? Andrew says a small dose of naloxone. Yeah, I think naloxone is an opioid antagonist that can reverse these effects. Andrew said small dose, probably because when we use naloxone in people who are getting opioids, we worry about causing a sudden change in the amount of opioid they have. You can actually even precipitate withdrawal in patients who are used to or tolerant to amount of opioid. And so you do often start on the lower end. Andrew says 0.4 milligrams would be my start. So that is a reasonable dose. I would actually say in anesthesia, we often still want them to have some opioid effect because a lot of times we're doing surgeries where they still have pain. So we often dose more like 40 mics at a time or really low and just titrate it up to effect where they start breathing well enough. And then go to the recovery room monitoring them very carefully. But 0.4 milligrams is a reasonable amount as well. All right, so we give naloxone. Patient starts breathing. We're feeling better. Some of our anxiety is starting to fade. We decide, you know what, we'll chalk this up as a learning opportunity. We're going to take this patient to PACU, and we head there. So you go to the PACU transfer care, you need to go get set up for your third case. So you're setting up for your third case. You're pretty worried about that last case, so you're going a little slow. It's been 45 minutes now since you gave naloxone and you get a page. Patient is already out of the recovery room. They're actually over in the preoperative holding area, and the nurse wants to get that patient out of here. Patient's doing great, no pain, no nausea, feels good, wants to go home. So what do you guys think? Should we say okay to discharge? Yeah, everyone's saying no. Matt here says we're worried that naloxone might wear off. I 100% agree. So especially when you've ran an infusion, you worry about the duration of your opioid effect being longer than the duration of the naloxone. So naloxone effect can wear off before that opioid does, and they can be at risk for respiratory depression, sedation again. So they need to be carefully monitored. How long? That's tough to answer because it depends on how much opioid you gave. Was it a bolus? Was it an infusion? What type of opioid was it? All those things come into play, including your dose of naloxone. But in this case, I 100% don't send this patient home. They need to sit in that preoperative holding, have a pulse ox on, and be monitored for a while until you're sure that you're out of that window. Andrew said naloxone infusion. Yeah, you can absolutely consider that too. And this patient, I'm hoping that we won't get into that, but if you ran a long enough fentanyl infusion, that might be something you have to do. It might be something where you decide this isn't outpatient surgery today. This patient needs to stay over with us. All right, we really got to get going on our third case because, the OR is already turned over. We were really preoccupied with providing good patient care, which is most important, but they're getting impatient. So we need to move on to our third case here. Maybe. There. All right, so our third case here says we have an 83-year-old man, BMI of 18. He's a classic lifetime smoker. So he's small, he's severe COPD, he's smoked forever. He's not yet on home oxygen, but he had a recent fall at home and he broke his distal radius. They casted it up, but he's coming in for definitive fixation of it. He's also expected to go home. The hospital's full like it always is these days. There's no bed, so this patient needs to go home after surgery. They're not expected to be able to stay over. He reports to you when you interview him in the pre-op holding area that he has had nausea in the past with anesthesia. He's also had severe constipation with opioids. So he's wondering, he says, "Hey doc, any chance that, I can do this without opioids, or is there any other alternative than general anesthesia? Because I've had so much nausea and issues with that in the past." What do you guys think? RAF of a distal radius. Do we have something else we can do for this patient that isn't? I see tons of people chiming in. Regional anesthesia, perfect. So let's just review side effects of opioids. So the picture on the right here shows that opioids act all over in the body. There's receptors everywhere. So there's receptors possibly directly in the peripheral tissues. There's receptors that act at our spinal cord and the dorsal horn. There's receptors that act in our brainstem and then all the way up into our cortex. So it affects, it affects pain going into the spinal cord, in the spinal cord, and our perceptions of pain. It also, as you can see on the screen on the left here, the image on the left, it affects almost every organ system in our body. Some of them are adverse effects. Some of them are effects that we utilize in anesthesia. So sedation, euphoria, those are outcomes that can be an adverse effect, but they can be used to our advantage when we're using them for sedation and anesthesia and providing anesthesia. So nausea and vomiting, really common with all opioids. Bradycardia, some of the synthetic opioids especially, can act on the vagal nerve and cause bradycardia. So large, big doses given quickly, you can see that effect. Pruritus, itching, really, really common with a lot of different opioids. Respiratory depression, like we saw in our last patient. The other things that we commonly hear about is it decreasing our gastric emptying or causing an ileus post-surgery. Urinary tension's another one that's really common. Muscle rigidity. So again, some of the synthetic opioids given in large doses quickly can actually give you muscle rigidity. So you might see that in, like, say, a cardiac surgery patient that you're doing a high dose opioid induction, and you can get muscle rigidity that actually you have to ventilate them through and even give neuromuscular blockade to get through. And then depressed cellular immunity. So we know opioids have this effect on some of the different immune cells. Whether that plays out into, clinical effects that we see, I'm not sure. They've done lab studies that have shown increased tumor growth with some of the opioids. But the clinical studies in humans, I think, is a little less convincing at this point, but I'm certainly not an expert in that. So you guys said regional anesthesia. I think that's a great option as an alternative for general anesthesia. So what is regional anesthesia? It uses local anesthetics that block our peripheral nerves, in this case, from transmitting those pain signals to the spinal cord and to the brain. So essentially, we're preventing that pain signal from ever becoming part of our consciousness. You might remember that local anesthetics work on the sodium channels, and they have to get intracellular on that nerve before they're able to bind to that sodium channel. So local anesthetics have to diffuse through the cell membrane until they reach that sodium channel and able to inactivate it at that point. So that's kind of why you might remember clinically when someone has, say, an abscess or something, and you want to inject local, that local doesn't work very well in that acidic environment because it becomes protonated, protonated form of it can't pass to its site of action and block those action potentials of the nerve. There's different types of them, esters, amides. We do not have enough time to go into all of that today. So suffice to say, regional anesthesia uses local anesthetics on nerves to prevent action potentials and that pain propagation. So let's go back to our third case here. We got 83-year-old guy. He's little. He's a smoker. Lungs don't work great. He's got to go home today. Okay. So what regional options should we consent for? So here is the table from your reading. It showed all the different types of blocks that they talked about. What area of the body are we focusing on here? What are our options for blocks that would work for this surgery? I see Christopher says brachial plexus blocks. I think that's great. Brachial plexus is what supplies the arm. He's having surgery on the arm. Perfect. So brachial plexus block. What do we mean when we say a brachial plexus block? Okay, so it's a collection of blocks here that we can do that target the brachial plexus at different sites. Where you target determines, or the anatomy determines kind of what the indications are and what blocks you do for different indications. So I know probably in med school you had to like draw out the brachial plexus. I'm not going to make you do that, but I am going to make you review it a little bit. So an interscaling block, one of the options for a brachial plexus block, targets the roots, mainly C5 root here, and you get some spread down a little bit. But when you inject there, you typically get C5, 6, sometimes 7. You often don't get spread all the way down to consistently get C7, T1. Your main concentration is up higher and blocking those nerve roots. So what you often lack is the ulnar distribution of coverage when you do look at dermatomes. So we predominantly use interscalings for shoulder surgeries. Things much lower in the arm, you really need that ulnar coverage, and it doesn't work for that. Supraclavicular blocks are more at the level of the trunks and the divisions, so that's just above the clavicle, supraclavicular. And you'd use an ultrasound here to see that plexus, inject local at that site. Supraclavicular and right below the clavicle, infraclavicular, work on the vast majority of operations that are done on the arm, especially slightly below the shoulder. So some of the branches that go to the shoulder come off really high, which is why we target that that's why we do an interscaling up high for those. Down lower though, proximal humerus and below, supraclavicular, infraclavicular work really well. And then as it turns into terminal branches, it becomes an axillary block. So that's done at the level of the axilla, given its name. And that targets the individual branches themselves. So this guy says, a needle, I don't know about this, doc. Maybe we go back to that general anesthesia and I feel sick for a little bit. Are there risks with this procedure? So what kind of risks do we talk about when we're doing nerve blocks and in particular brachial plexus blocks here? I see a couple people say pneumothorax. Yes, so pneumothorax is a risk with some of these. There's some other risks I want you guys to talk about too. So keep working. Tell me some of the other risks. Ashley says diaphragmatic paralysis. Absolutely. So we can get that last. Yes, I agree. Last is a risk anytime we're doing a nerve block. Infection. Anytime we put something through skin, we have infection risk. Subclavicular vessel infiltration. So like bleeding, or if you injected your local into the vessel last, like we said. So I agree, that's certainly a concern. Hematoma, yep. So hematoma could happen from that. I think that is the majority of them. So there's effects that can be from the needle. There's effects that can be from the local anesthetic. And there's effects that can become or from the needle damaging not just the nerve, but surrounding things as well. So like pneumothorax. So the local anesthetics when you're doing brachial plexus blocks, do cause hemidiaphragm paresis by blocking the phrenic nerve that runs actually right by this brachial plexus. When we do an interscaling block, the incidence of phrenic nerve block is 100%. So everyone has some degree of phrenic nerve block, or at least that's what we're taught and what we see clinically. Supraclavicular is down a little bit further. We're a little bit further away from that phrenic nerve, but it's still about 50%. Even infraclavicular below the clavicle, we can see up to 25% or so. So depending on your volume and things like that, you can still get spread all the way up and get that phrenic nerve block. And someone said pneumothorax. Yes. So pneumothorax is a risk. It's rare. But you can get a pneumothorax with an interscaling, a supraclavicular, and an infraclavicular. What do you guys think about, is a pneumothorax a risk for an axillary block? Andrew says no. Everyone agree with him? I agree with him. So you're not by the thorax anymore. You're out on the limb. So there's no lung there. And you're so far away, you're not going to get spread to that phrenic nerve either. So in this patient who lungs don't work well, barely oxygenates well enough currently, and has to go home today, what do you guys think about an axe block? I think it'd be a great option. So let's say we choose an axillary block. We can send them for those risks, and we move on with the case here. All right, so an axillary block, they put their arm out to the side. You put your ultrasound right over where the axillary artery would be, and you get to image up here on the left, or excuse me, on the right. Your needle would be coming in from the top, which in this case is lateral. So be here on the left, you can see it coursing over, and you can see some local anesthetic, which is denoted LA, coming out of that needle tip, with the A denoting the axillary artery here. Nerves around this area, so you can see that there is the radial nerve just off the tip of the needle, ulnar nerve kind of about 2 o'clock, and the median nerve about 10 o'clock. So typically you see this sort of arrangement. Sometimes radial is a little bit more like 6 o'clock here on the vessel, but it might have got pushed off with some of that local anesthetic we've dosing. So we do this block here. It goes really well. He has no pneumothorax because that wasn't a risk. We don't hit the artery. We don't see any bleeding. His vitals remain very stable. We don't see any evidence of last. So we are feeling very good about ourselves. So we picked a great anesthetic for this patient. Then your attending comes and says, can you check if the block is setting up? And you're like, what does that mean? So what does check if the block's setting up mean? How would you do that? What are you checking? What do you guys think? So it looks like Mohammed here says pinprick. Yeah, so you could use pinprick. So if they can feel pain from the pin, obviously not working. There's something else we can use that works too, especially if you don't want to hurt someone. You're not sure if it's working. I mean, this is your first block. We don't want to start cutting people yet. We got to make sure that we think that this is in. Muscle tone. So motor block is a good sign that probably you're going to get a sensory block too. So motor block's a good indication that your block is setting up. And Esdras is cold. Yeah, so pain and temperature travel on the same nerves. If they lose, or if the ability to detect temperature is decreased, that's a good sign that that block is working. So we get some ice, we put it in a glove, we tie it off, we take that ice over to the patient, and I do this all the time in patients, and I touch it to their unaffected arm, and I say, does that feel cold? And they say yes. Otherwise, I worry I give them too much sedation if they don't say yes. And then I move to the arm that we did the nerve block on. And I say, does it feel the same or different? And they say, oh, it feels different. I don't really feel cold. Are you touching me? And they say, I can still feel the pressure, but I don't feel the cold. And you say, perfect. I blocked the nerves. It's setting up well. So let's say we do this on this gentleman, and you can see our dermatome and cutaneous innervation diagrams here. And let's say the lateral forearm isn't covered. So let's say it's the lateral antebrachial cutaneous. He feels cold. He feels nothing anywhere else. He's like can't move his arm anymore, but he says he can feel cold over that part of his arm. What do you guys think is going on? Is he losing it? Did anyone know why we might see that after an axillary nerve block? The reason that I bring this up is because every block that we do has pluses and minuses, right? We avoided issues with blocking the phrenic nerve by doing an axillary block. We avoided the risk of pneumothorax by doing an axillary block. And we know that that's the brachial plexus. I told you that it can be used for anything kind of mid-humerus or distal humerus and below. That's where this is. But we did a good block. Why isn't it setting up? Well, if you go back to that picture that we have, you can see that the muscocutaneous nerve is right here. That's what actually becomes the lateral antebrachial cutaneous. And if you don't, that comes off of the plexus really early on. And so it can be quite a distance away. It travels in the coracobrachialis muscle. And so you have to separately target that with your needle. Injecting local just around the axillary artery in a large number of people won't block that nerve. And so you have to separately block that. So we forgot to do that. So we are aware of that now. We tell our attending where we're missing. And your attending supplements that muscocutaneous. So they inject a little local around that site. Then the block's working great. No sensation of cold, no movement. You go back to the OR, you do the case, the patient is awesome. You avoid any opioids whatsoever in this patient. You give very light sedation because of his respiratory issues. You take him back straight out to pre-op area after the OR because he's wide awake already. He's at his baseline oxygen saturation. He gets put in a sling because he still can't move his arm because that local is going to be working for a while. But he's very happy. He says this is his best anesthetic he's ever had. And you feel really good about yourself. And you should. That's something cool we can do in anesthesia, and we can really change how people get through surgery by using some of our knowledge to our advantage. He also says he'll take your advice, he'll consider taking your advice to stop smoking. When you're an anesthesiologist, you should use that time with your patients to counsel them. I don't know if they'll listen, but sometimes they do. So take every opportunity you can to help your patients. All right, we're tired. There's a lot going on today, but we got one more case to do, and it's our biggest case of the day. It's a 52-year-old female. She has advanced endometrial cancer. She's coming in for a radical abdominal hysterectomy. She's had a history of a DVT in the past that was not provoked. She's maintained on a Pixaban for that. They held it for a few days in preparation for surgery. She's got some mild neuropathy they think is from chemotherapy in the past, and she takes gabapentin for that. Otherwise, though, she's heart, lungs work well. You can see her labs here, essentially normal, near normal values, normal renal function. So your attending says, hey, this patient's a big surgery, going to be a big midline incision. I'm worried about pain control for her after. Can you come up with a good plan to address the severe pain that might happen post-operatively for this? So what is multimodal analgesia? So let's see. What do you guys think? What is multimodal analgesia? I'm sure you've heard those terms. It's like a buzzword. That's a good answer to everything your attending asks you. What do you guys think? Multimodal analgesia. Multiple pain control modalities, preventing overdoing one type. Yeah, perfect, guys. That's exactly what it is. So it's using interventional techniques or multiple different types of medicine designed to maximize our analgesia, minimize side effects from any one of those medications. Really, our goals are improving patient recovery following surgery. So improve their pain control so they can ambulate early, minimize opioids, and encourage early parenteral nutrition to get early return of bowel function, decrease the stress response that we know has a lot of deleterious effects on patients post-operatively, and acutely controlling pain is actually thought to have a role in decreasing the risk of chronic pain after surgery as well. The key here is, really you got to think through these different types of medications and tailor it to your patient. So I have a little diagram here that shows different medicines that are commonly used as part of multimodal analgesia. So local anesthetics, just like we did on that last patient, are a great thing to add. So that can be in the form of a peripheral nerve block like we used on the last patient. It could be an epidural, spinal, or intrathecal administration of local anesthetic. And it can even be a lidocaine infusion that goes through the IV. So there's evidence that in certain surgeries that actually promotes recovery quite well. NMDA antagonists, NMDA receptors are known to play a role in the pain response. NMDA antagonists, most common one you've heard of is ketamine, can play a role. Magnesium actually has some analgesic efficacy. It's thought to act through an NMDA receptor. Opioids, certainly, they're our best pain controller. So we often use some of those. Acetaminophen, NSAIDs, so most commonly ketorolac or ibuprofen, and then alpha-2 agonists. Most commonly dexmedetomidine, clonidine, gabapentinoids, pregabalin, gabapentin. Dexamethasone has an analgesic effect, especially at higher doses, not quite as much at the PONV doses, but certainly something to consider. SNRIs, duloxetine has maybe a small role as well. So all these things can be used in patients, and just like we learned the side effects and pluses and minuses of different medications for the opioids in particular, you got to do the same thing with all these medicines, but using a combination can provide better analgesia and decrease the amount of any one you give to decrease the risk of serious side effects. So what should our plan be? What do you guys think? Which of these for our patient might we want to incorporate? So I see a lot of regional options. So it looks like you guys want to use local anesthetics. I think that's a great idea. What do you guys think? Ketamine? Should we use opioids? Ketamine? Tylenol? NSAID for post-op, people say. Sure, I think that's a reasonable idea. Gabapentinoids? What do you guys think about gabapentinoids? This patient was already on it. I see maybe we can use opioids in the form of a PCA. She might have a tolerance. Yeah, these are all great ideas, guys. So thing to remember, so gabapentin has some mixed evidence. I'd say the general evidence trend is less in favor of utilizing gabapentin in everyone because of some of the sedating side effects when combined with opioids post-operatively. And all of these things have some of those things. So Victoria says scheduled NSAIDs, Tylenol, breakthrough pain opioids, don't decrease current dose of gabapentin. Okay, sure. So here, I'm just going to go through this would be a very typical plan. So I break it up into what do we do before surgery, what do we do in the OR, and what do we do post-operatively. So in this case, I think giving her a gram of Tylenol preoperatively and is a great idea. Taking her home gabapentin makes sense to me. And then, there's a lot of regional options. In this case, I said, why don't we talk to her and see if she's interested in a thoracic epidural? We know she's gonna get a big midline X-lap incision. Epidurals are kind of our gold standard for pain control afterwards. After that type of surgery, We know she's going to be in the hospital for several days. It's a reasonable option. Intraoperatively, so we could give her a P1V dose of dexamethasone. In a patient who has an epidural, you can run the epidural during the case. The drawback of that is it blocks your sympathetic nervous system. It can lead to hypotension, and it can make it harder to treat hypotension if you get into significant bleeding intraoperatively or hemodynamic instability. But this patient's actually really healthy. Her heart and lungs work normal. This is someone that I would consider running a low rate of an epidural infusion in the OR. I like to try to minimize opioids in the operating room if we can by using some of these other adjuncts. A ketamine infusion run during the case, I think, is a great idea for this person. Usually give a bolus dose and then run an infusion rate. These are sub-anesthetic infusions, so it's not like the ketamine dose that you would use to induce someone. It's much lower than that. And then I would discuss ketorolac as an NSAID component with the surgical team. So with NSAIDs, you always have to be mindful of a patient's age. So someone say older than 65 and ketorolac don't mesh well. There are increased risks of some of the GI side effects. And then there's some evidence that NSAIDs like ketorolac can increase bleeding risk in certain surgeries. So you got to always think through the surgery, talk with your surgeons, and come up with a plan together. And then post-operatively, I would run this patient with a local anesthetic combined with an opioid via the epidural. I would schedule Tylenol, and if we were okay with ketorolac, I would schedule that every 6 hours as well. And then I would see how the patient does in the recovery room. So some of these patients, even despite all these, might need a PCA with opioid, like someone suggested. I think I would start with just an as-needed IV opioid available and an oral opioid available once they're tolerating oral intake. And then if it looks like they're going to need more, maybe add a PCA to give them better control of their pain post-operatively. So I think those are all great ideas that you guys had. Let's go with this plan. So let's review kind of what a thoracic epidural even is first before we go into how it's working for the patient. So I'm sure most of you have heard of an epidural, seen epidurals. They can be put in all different spots in the spine. What it really is designed to put a catheter in the epidural space, which is the space just outside of where your spinal cord runs and where the CSF is located. So it's not actually intrathecal. It's not in the CSF. It's on that fat-filled space outside of it. Depending on where you put it determines, and your infusion rate determines what dermatomes you cover. And so you need to center it around where your incision is going to be. For this patient, we expect to have a midline incision. That's going to take up most of her abdomen. So I would say centering it somewhere around like T9, 10, belly buttons about T10 is a good idea. You're going to get some spread up for dermatomes. You're going to get some spread down, but that would be most likely where I would put that epidural. And you can see different surgeries require epidurals to be placed in different places. And where you place them have dramatic effects on what you see with them. So what nerves you block. When you put a thoracic epidural in, you can run it at a rate such that usually you don't get spread to the lower extremities. And so these patients are still able to walk, their legs work normally post-operatively, which in someone we want to get up and mobilize early is obviously important. If you put in a lumbar epidural like we do in obstetrics, with our typical infusions, they very well may have numbness, tingling, weakness that you wouldn't want them to be walking around with. So these things are important to think about. The epidural procedure itself involves using a needle to find that epidural space. And we do that by using a loss of resistance technique. So you can see here in A, we have them all prepped out, draped, because infection is very important to be mindful of. If you get an infection in the epidural space, you can get an epidural abscess, can have pretty severe complications. So we take infection very seriously. Then we localize the site with lidocaine or something fast acting. And then this stripe looking big needle is a 2E needle that we use for epidural placements. We use that to go through the different layers to get to the epidural space. So we go through skin, subq, supraspinous ligament, interspinous ligament. You go through a big ligamentum flavum. And then you can see the syringe in F here is filled with saline. So as you're going through those different layers, you're tapping on the end of it. And when you're in a thick ligament-like tissue, you aren't able to inject any of that saline. There's a firm resistance that you're met with. So you tap on it, the syringe, which is freely moving, doesn't inject, and you advance slightly further and you do the same thing. And you do that all the way until once you pop through ligamentum flavum, you tap on that syringe and all that saline gets injected very easily because it's a big fat-filled space that can absorb a lot of fluid. And that's how you know you're in the correct spot. Once you're there, you take a catheter, you thread it through that needle, you pull your needle out, you leave a certain amount of catheter in the epidural space, and then you tape it down. And then you hook it up to medication like an opioid and a local anesthetic to get its intended effect. So on our fourth case of the day, you follow the plan, the case proceeds smoothly. You check on her in the recovery room. She's sleepy, but her pain is really well controlled. PACU nurse is happy. You remember how to perform a dermatome test from our last patient. So you check her level. So you tell your attending she has a good bilateral level. So meaning we checked with ice or something sharp. We saw that on both sides of her abdomen, in the area where her incision is, we have decreased sensation to cold. That means she has a good bilateral level. Epidurals can sometimes have effect on just one side or the other. This allows us to find a good, reassures us that it's working and it's working in the right location. So she goes up to the floor. Her pain regimen there's just as we designed. She has not even required IV or PO opioid therapy. So the epidural and the other medications that we've scheduled have worked for her really well. So you're feeling really good about it. You're about to go home for the day. You're tired. It's a long day. A lot of patients that we had to deal with, a lot of issues. And you get this page. Patient has severe itching. Rex. How should we manage this? Is this even our problem? Is this something surgery deals with? Because, I mean, can you get itching with these medications? We're not even giving her any IV or PO opioid medications. What do you guys think? What is this itching from? Type it out. We're almost done. We only got a few minutes left. Is itching a side effect of the local anesthetic? Usually it's actually a side effect of the opioid that we're administering neuraxially. And so if we go to this next slide here, the most common side effects that we get with in epidural or neuraxial analgesia, urinary retention, pretty common actually, especially in the old men postoperatively. Nausea, vomiting, and itching, pretty common. That's usually from the opioid effect. Motor block can happen. That's more from the local anesthetic effect. In a patient with a thoracic epidural who stops moving their legs or has a motor block of the legs, you have to be pretty concerned, like because of what we just talked about in terms of where an epidural is located, that might not be from the local anesthetic. That may be something like an epidural hematoma that is compressing the spinal cord, and that's an emergency that needs to be dealt with or can result in permanent neurologic injury. Hypotension is usually a result of the local anesthetic, not the opioid. And then respiratory depression. So you can see that with neuraxially administered opioid, although the amount that's systemically absorbed is much lower than what we see with big IV doses of opioids. So really, we're minimizing the systemic effects when we're using neuraxial opioids as an alternative. The chart here on the left is from an article in Anesthesiology that shows essentially with just straight bupivacaine or local anesthetic, you have increased hypotension and motor block, but you decrease all the risks that come with the opioid administration. And as you go down the chart to no local anesthetic and just higher dose opioid, you decrease your risk of hypotension and motor block, but you increase your risk of nausea, vomiting, itching, sedation, respiratory depression. So using the combination, you try to find a balance that works well. In this case, this patient is hemodynamically stable, pretty healthy, doing well post-operatively. She might handle the sympathectomy that happens with more of just a local anesthetic. And it might be worth switching over to that despite some of the loss in analgesia you'll get by reducing the pruritus by taking the opioid out of the solution. So let's say we take the opioid out of solution Another alternative would be administering a partial agonist like nalbuphine that can actually work for itching from neuraxic opioids as well. But we take it out, we go home for the day. The next day, you're setting up for your series of cases. You get a page from the nurse. You were so nice to the nurse when dealing with this itching, and it works so well that they want your opinion. Surgery team ordered apixaban to restart today. Are we fine with that? What do you guys think? Can you restart apixaban in this patient today? It has been, a day since surgery. Is there anything else we're concerned about? You guys think of what we might be concerned about for a anticoagulant in this patient? Andrew thinks it needs to be longer for an epidural. Yeah, so you actually can't administer apixaban with an epidural in place. And we worry about both with needle and with the catheter being there that we could get Colin, perfect, an epidural hematoma. Just like we talked about, that can be a neurologic emergency and cause permanent nerve damage that I've seen happen. And so we take it very seriously. So no, I would say absolutely not. This patient can't start apixaban today. If they need to start apixaban today, then we got to take the epidural out. So I won't go into this too much other than to know the American Society of Regional Anesthesia produces guidelines on the epidurals and all the different types of blood thinners and anticoagulants that exist. It gets complicated, so they make an app. They also have a website that you can review to see what's okay and what's not okay and what the guideline is. So check that out. So surgery wanted to start the apixaban. They were really worried about her history of DVT. So despite the great pain control, we have to take the epidural out. So we take it out so they can restop our apixaban. But then, the patient initially was very happy with this plan because she doesn't have any pain. I don't care if you take the epidural. So we take the epidural out, but several hours later, you get a page, patient with increasing pain. Turns out the epidural was doing something. Options. What options can we make? Can we offer anything else to this patient? So the epidural's out. We're not going to put it back in. She's on apixaban now. She's on scheduled ketorolac. She's on scheduled acetaminophen. The IV bolus from the nurse of opioid isn't cutting it anymore because the pain's so much worse. Write out a couple other ideas. Andrew thinks we could maybe do another type of block. I think that's a great idea. Tap block even. I think that's perfect. I think that'd be a great idea. So there's a few things you can consider. Tap block is another alternative. So it catches the nerves that go to the skin of the abdomen as it passes through three different muscle layers in our abdomen, the external oblique, internal oblique, and transverse abdominis. It runs between the internal oblique and transverse abdominis. So injecting local anesthetic between those layers can catch those nerve endings spread up and down and anesthetize the anterior cutaneous branches that innervate the skin of the abdomen. We could also consider ketamine, like we use that intraoperatively. We can use that at sub-anesthetic doses postoperatively too. Certainly, if we didn't already order a PCA, adding that in would be a good option for her. But the tap blocks might help us avoid some of those opioids. Ketamine also might be opioid sparing. So the following day, her pain's controlled, and she recovers uneventfully. So my goal really with this lecture is to provide some clinical context. So you can see that as you work through all this material, it can be overwhelming. Sometimes it doesn't feel very relevant, but it all plays out. These are cases that I see every single week. This is what we do. The knowledge you acquire through your readings and through your clinical rotations can really improve the care of patients. And I'm biased because I'm a regional anesthesiologist, but I think regional anesthesia and pain management is super fun. It's like a puzzle piece. It's like puzzles that we're putting together for every patient, for their comorbidities, for the type of procedure they're getting, for their preferences. And you can really change things to make a real difference in patient care, satisfaction, and patient outcomes. So I think it's awesome. I'll end there. I know we're even a couple minutes late, but here's some pictures of our residents, fun things we do. If you like Instagram, you can check out our Instagram. I don't know if we have time for any questions. Otherwise, we'll wrap it up.
Thank you, Dr. Meyer. I think we'll wrap for today.
All right. Well, thank you all for joining. Good luck on your rotations or starting residency. It's great to see such a good showing for people interested in anesthesia.